I'd like to now introduce Dr. Samantha Nutt, who is the founder and executive director of War Child North America. Dr. Nutt was recently named one of Canada's 25 Transformational Canadians by the Globe and Mail, and she's been appointed to the Order of Canada's highest civilian honor for her contributions in improving the plight of young people in the world's worst conflict zones.
Well, thank you very much. It's such a pleasure for me to be here, back at the University of Central Florida, but in Orlando as well. I spoke at the university about almost 2 years ago now, and so as you can see, when I was getting on the plane coming from Toronto, where it is officially winter, by the way, I thought that I was heading into summer, and. Yeah, you guys didn't tell me the truth about that one, but I'm honestly, I'm so happy and excited to be here. And the last time I was here, I think it was probably about 95 degrees. So I was given a very humbling education around the Florida weather this morning when I arrived. Now, it's. I think I do want to start with just a reflection, because for me. To be here as a guest of the Legacy Fund and hearing the story of your son, Don Diebel Jr., to me, it reminds me, with the work that I've done all around the world, there have been times when I felt like I didn't want to do this work anymore. And sometimes the hardest moments for me have been when the people that I knew and loved and cared for and who inspired me, and who put it all on the line, and who were those people who always went further and did more and was so gracious and generous, and who lost their lives in the pursuit of that goal. And I know how hard it is to lose somebody under those circumstances. But I also know that with those experiences comes great courage and great strength and great inspiration. And I just hope that for all of you here this evening, that you see that legacy continuing every day in people that are here, that are participating, and who see the strength and the extraordinary courage that your son brought to the world. Those are the people that keep me going, and I hope he does for you as well. So thank you very much. I really appreciate that. Now, I come, as I said, from Toronto. Some of you may know a little bit about Toronto. It's an interesting place these days, politically. We're making news all over the place. We're making news because of our mayor, Rob Ford. If you've been watching Jon Stewart lately, and everybody else, yeah, Toronto is now on the map. It's fantastic. Not for our universal health care, not for our kind, compassionate societies. Nope, we are on the map because of Rob Ford and his famous one-liner, which can now be added to all the great one-liners in political history, on top of Ich bin ein Berliner, and I had a dream, and I am not a crook. We can now add Rob Ford's I probably smoked crack, probably a year ago when I was in one of my drunken stupors. And the crazy thing is, last week in Toronto, another video of him surfaces, and you couldn't write this stuff. Another video of him surfaces, and he's behaving erratically and threatening to kill somebody and poke their eyes out and then come back 10 minutes to make sure the body is dead. And so he gets asked about this in the press, and the response was, I was extremely, extremely intoxicated. Whatever political problems you think you have going on here in the US, believe me, they can't even begin to compare to what our lives have been like for the past few months. Now, this evening, obviously, I'm not going to talk about Rob Ford or the weather in Toronto. I'm going to focus my comments on a couple of areas. And I want to talk very specifically about some of my experiences working in war-torn countries around the world and the links between medicine and public policy. And I really do believe that this is a very important time to be talking about these issues. I mean, you don't have to even do anything more than turn on the news, and you are confronted by the very important links between people's health and welfare and our social and political and economic climate around the world. And whether you're talking about Syria, or whether you're talking about Darfur, Sudan, or even most recently the terrible typhoon that hit the Philippines, in which they are struggling to overcome at this moment in time, we see just how closely linked some of our health concerns are with these very other important geographic and political realities. And I know that so many of you here are involved in international service work, and I really do want to commend you on those efforts. So one of the other things that I will talk about this evening, but towards the end, is I want to talk about some of the do's and don'ts that you might consider, and this is specifically for the students, when it comes to international service work. And if you're interested in the kind of career that I have had, I don't necessarily recommend it. Your parents will not be happy with me. My parents are not happy with me, so I'm just speaking from personal experience. I am going to talk a little bit about how it is that you might get started and what kinds of things that you should be thinking about. And I really think that when it comes to medicine and public policy and the bridge and the linkage between the two, unfortunately, this is a place where we so often fail in the healthcare sector. And we fail because most of us as health professionals, we just don't want to get bogged down in those big questions. We say, oh, well, you know what, don't bug me. I don't want to talk about politics. I just want to see patients. I want to make people better. And we don't want to really wade into that messier, somewhat nebulous subject of the broad determinants of health. And the broad determinants of health are interesting because as important as they are, they also tend to be that thing when you're in medical school. How many of the students here are in medical school? A bunch of you, right? That's the broad determinants of health, that's that subject that kind of gets pushed to the side because it's not going to be on the exam. And if it's not on the exam, it can't really matter, right? It's the fuzzy side of medicine that no one's ever going to ask you about or test you about. And yet what I've discovered over the years is that that is probably the most important part of our work as physicians, wrestling with some of these questions. And what I have confronted over the years is that not only do we not do a very good job of finding the answers to those questions, we don't, in our medical education, do a good enough job of asking the right questions in the first place. And so with that in mind, I'm going to start with a question of my own, and this is specifically directed at the med students, because I'm going to put you on the spot here. And I'm going to ask you, I'm a public health doctor, I'm going to ask you, demographically speaking, what do you think is the single most important determinant of whether a child in the developing world, the global south, will live to see his or her 5th birthday? Now, how many of you would say access to primary health care, free, affordable primary health care? That's the single most important determinant of child mortality in the world. Nobody? How many of you would say food and water? That's the single most important determinant. A couple of you? How many of you would say something like, I don't know, mosquito nets? That's a cheap way of saving lives, distributing mosquito nets, keeping people alive, helping kids. Anyone? A couple of you? There are more people in the developing world who die every year from smoke inhalation due to kerosene and charcoal cook stoves than die of malaria, even though it's still a significant contributor to morbidity and mortality around the world. How many of you would say access to HIV medications? Particularly when we're talking about Africa. There you go, that's a really important thing that we could do that would determine whether a child lives to see his or her 5th birthday. No one? Who knows what I missed in that list? What is the single most important determinant? Anyone? Single most important determinant of whether a child, demographically speaking, in the developing world will live to see his or her 5th birthday is that child's mother's independent access to income, which is by extension about education. You know, there's a fascinating study that was published in The Lancet. It was funded by the Bill and Melinda Gates Foundation. It came out in September of 2010. And they took 30 years of demographic data, going right back to the 70s, 30 years of demographic data from the developing world. And they found, looking at that data, hundreds upon hundreds of thousands of cases. that for every extra year of education, on average, that girls in the developing world receive, child mortality drops by 10%. So I'm going to say that again. For every extra year of education on average that girls attain, child mortality drops by 10%. So what does this mean? It means that we know increased education levels, especially among girls, that this lowers maternal and infant and child mortality the world over. And we also know that increased education levels reduce fertility rates and improve quality of life indicators. And we also know that increased education levels and empowerment of girls in particular, that is positively associated with a reduction in the spread and likelihood of armed conflict and violence within the household. And yet, none of these answers fits into that narrowly defined clinical or medical view of global health, the kinds of questions that we usually see on our exams. And all of that can be achieved for a fraction of the cost of our ongoing global militarization. You therefore cannot talk about maternal and child health, for example, without understanding the importance of education and economic development everywhere in the world. The effective practice of global health, it's got its own formula. Are you ready, students? You can write it down. Here it is. This is 20 years this has taken me to figure out. 20 years. This is my E equals MC squared. Here it goes. And if you can recite this back to me without checking your cell phones because you've recorded it afterwards, come see me, because you're exactly the kind of people that we want in the NGO sector. The effective practice of global health is 1 part science, 1 part anthropology, 1 part sociology, 2 parts history, 1 part economics, 1 part epidemiology, 3 parts simple intuition, and 10 parts the act of effective listening. But fundamentally, it requires a naturally inquisitive mind with the discipline to not presuppose the answer, because it is in presupposing the answer that all too many aid efforts fail. We think we know best, and we don't, and we think that we're right, and unfortunately, we are too often wrong. And so this is the context that I want to talk about this evening, because my experiences as a public health doctor working in war-torn environments all around the world have taught me that global health is not a medical conundrum that must be solved. It is actually a narrative, and it is one which is poorly understood and incompletely told. And it is only by wrestling with this narrative side of health, that a more thoughtful and considered view of humanitarian action begins to emerge. And it's for this reason that tonight, as you may have noticed, I don't have a PowerPoint here running. I know in medical education that's really radical. Makes me somewhat of a renegade. But that's what you get when your keynote speaker is a nut. Oh, come on. That's right. Listen, I'm not the only nut from Toronto these days. But I am going to use this narrative approach, and I'm going to tell you some stories in order to make my point. And my first story begins where it all started for me, professionally and personally, and that's with these 50 cents, 2 quarters. And in a way, it's a fitting story for me to tell this evening, because it was an American lawyer, a man by the name of Pierce Garrity, who worked for UNICEF and UNHCR, who was my first mentor when I was 24 and interested in the field of international health. And I met Pierce when he was the director of UNICEF's operations in Somalia. And I had just graduated from medical school, and I was finishing a master's degree in public health at the London School. And he had approached me because I was doing some thesis research work around women in conflict. And so Pierce was pulling together a team, a maternal and child health evaluation team, to look at some of the challenges that were facing populations in Somalia. And you have to understand some of the context at that moment in time, because this was the early mid-1990s. And it was right after the withdrawal of troops that were deployed under President Bill Clinton under Operation Restore Hope. And you may remember some of what happened in that situation and the Black Hawk Down incident, or you maybe have seen the movie. And so the world had really begun to turn its attention from Somalia and towards Rwanda, where there had been a very devastating genocide. And one of the difficulties with the situation in Somalia was that in addition to the increasing insecurity, with the attention focusing elsewhere, with the world feeling as if its reputation had been bloodied and sullied in that part of the world, Somalia no longer really seemed to matter, not to international organizations, not to international funders either, and certainly not to the press, and definitely not to Western populations. And one of the great difficulties was that with the Rwandan genocide, Somalia had gone from having about 200 international organizations on the ground, running everything, healthcare, education, absolutely everything, because there was no functioning government. And within 6 months of the Rwandan genocide, there were fewer than 40 remaining within the country. So you can imagine all health services just virtually ceased to function. And Pierce's job was to try, in the midst of this chaos, this frenetic and lawless environment, to try to figure out, what the heck do you do? What are the most urgent risks and the most urgent priorities when you have only a small amount of money? What are you going to spend that money on? And so he was putting together this team, and I was the only female on the team, and he asked me if I would conduct the women's health assessment piece and make my recommendations, which would then be presented on the floor of the UN Security Council. And it was interesting because he said to me, look, here's our situation. We've got no budget. You're 25. I can't really pay you. He said, but I have to put you on contract because, and I'm getting back to these 50 cents in a second. I have to put you on contract because if the UN issues an evacuation order, you have to have some kind of payment in order to be covered. And so he sent me a contract for me to do this work in Somalia, my first experience in a war zone, but not in a developing country. And he sent me this contract to do this work for exactly $1. And I remember standing in Nairobi at Kenyatta International Airport on the tarmac, getting ready to board this 6-seater World Food Program plane. It was the smallest plane I had ever seen in my life. Boeing, Boeing, Boeing. What is that? Oh, that's your plane. Oh, that's... And I was standing on the tarmac, and I turned to him and I said, Pierce, I've been giving this some thought. And he said, you have? And I said, yeah. As he hands me his flak jacket and helmet. I said, I think that maybe Somalia is a little bit dangerous. And he said, and you're figuring that out now, Nutt? And I said, yes, I am. And he said, well, what would you like to do about that? And I said, well, I think I'd like half the money up front. And that was when he slipped me 2 quarters. 2 American quarters, actually. These are Canadian quarters because I spent all my American quarters on the tolls. But he slipped me these 2 quarters, and I love these ones, but yeah, 2 other quarters, and I put them in my pocket and set off into one of the world's most dangerous places. And it was a decision that changed my life at a very young age, but changed the course of my professional career forever. And I'm going to put these 2 quarters here because I'm going to get back to them towards the end of my presentation. But before I do that, I want to explain to you what it was like arriving in Somalia. I was based in a part of that country that was known as the City of Death by Western journalists. And it was called the City of Death by DOA because about 250,000 people had died, mostly from famine and war-related causes. And when I arrived, they were going through a very devastating second wave of the famine. And driving even just from the airport to the UNICEF compound, it was a crazy, lawless environment, and you could see just the level of desperation that people were living with, and it was not uncommon to see bodies in the street. And I remember very distinctly one afternoon, I arrived in Somalia like a lot of other young physicians would have, believing, pretty confident, believing in my skills, believing in my abilities, believing that I could save lives. And it didn't take me very long to realize just how deeply flawed those assumptions actually were. And I remember one afternoon, 2 days after I arrived, standing interviewing women who were waiting at this feeding clinic, holding their infants, waiting to be seen. And the line snaked all the way around this particular building, and I'm standing there with my clipboard, my professionally designed questionnaire, getting ready to write my big report. And I'm going through my list of questions with my translator with the women that are standing in line. And I remembered about 20 minutes into this one conversation, I did something fairly innocuous. I just had been talking to this woman, and so I leaned forward and I tried to put my finger in the palm of her baby's hand. And when I did that, I discovered that the baby was already in rigor, so stiff, and had already succumbed to her injuries hours before. And yet here I was, 25-year-old young physician, thinking that I was in Somalia saving lives, asking her inane questions for 20 minutes about how she felt about her health and the risks that she and her infant had been facing and their priorities. And it forced me to confront a very uncomfortable reality. And the reality was that famine, as I quickly came to understand, it wasn't actually a medical failure. It wasn't simply a question of adding more feeding clinics and distributing more high-protein biscuits. It was first and foremost a political failure. And the international policy questions in Somalia were indivisible from any response that we were trying to mount to meet people's healthcare needs. And why was that? Well, you see, women like the young woman I was talking to in line, what had happened to her was she had left her village and she knew her child was unwell. She had sold all of their remaining livestock to get this ride into town that was about 3 days away at the back of a pickup truck, knowing that her child was unwell. And she was stopped by some young boys, militia, on her way in. And they detained her for 2 days while they tried to extort her for money as her baby was dying. And there was nothing that she could do about it. And she was standing in line not because she didn't realize that her baby was dead. In fact, once we started to talk to her, she did know, pretty much knew that her baby was dead. But she was standing in line still because she had paid them all of the money that she had for her return journey and the money that she had to bury her child. And she just didn't know what else to do. And this was the hard reality of working in places like Somalia. Because the real dilemma for aid workers and international organizations and civil society groups back then, even as it is today in Somalia, it wasn't a question of, well, how do you go about slowing this tide of death and disease and starvation? Because we actually know what works in those environments. You reestablish the cold chain, you vaccinate priority groups, you set up short-term food distribution programs. That's what you do to keep people alive, if you have to. The reality was that none of that was possible in the face of drugged-up, trigger-happy, adolescent boys armed with Kalashnikov rifles who sabotaged that progress at every single turn. And in truth, as aid workers, we could chronicle the loathsome absurdity of all of this. But let me tell you that we could do precious little to stop it. And it is a very sad, I think, commentary on our world that even right now, in places like Somalia, where infants can die of dehydration while waiting for treatment at feeding clinics. Places like that, automatic rifles are still more readily available and accessible than clean drinking water. How does this happen? Well, this is a local problem, absolutely. It is the inevitable consequence of the legacy of colonialism in the region. It is tied to some very pronounced ethnic divisions and disintegrated Cold War alliances. It is also about failed foreign policies and failed interventions, and certainly a warlord culture. But it is a global problem as well, and it is one that ties very specifically to our public policies. Well, how so? Well, you see, any effort to reduce infant and child and maternal mortality depends on one thing. It depends on access. Access on the part of those who need the services, and access on the part of those who deliver the services. And the worldwide pandemic of weapons and the militias that rely on them around the world to rape and to threaten and to intimidate at will are among the biggest obstacles to advancing global health in existence in the world today. And we only need to look at that global context in which this weapons crisis is not just thriving, but growing, to understand how public policy can have an impact here. So what is that context? Well, I'm going to ask you here a question, back to the students. How many Kalashnikov rifles do you think that there are in the world right now? Any idea? Who thinks it's more than 50 million? Who thinks it's more than 100 million? Who thinks it's more than 200 million? How many of you think it's closer to 500 million? You'd be right. So of the ones that we know about, that are registered somewhere, that were lawfully exchanged, there are roughly 200 million AK-47s in the world. But it is estimated that there are at least 2 for every 1 that we think that we know about, taking that total to closer to 500 million Kalashnikov rifles. And if you extend that to include all small arms, and a small arm without irony is anything that you can pick up and carry. So it includes things like rocket launchers and machine guns. If you include all of those, it is well over 1 billion of them in circulation in the world today. And if you're in Somalia and you're looking to procure an illegal weapon like a Kalashnikov rifle, or anywhere in a parallel market in a developing country, how much do you think that will set you back? Who thinks it would be more than $100? How many of you think it's less than $100? You're right. It is on average, certainly less than the price of admission to Disney World, but it is on average about $30 to $60. These are lightweight, virtually indestructible, steel-killing machines that with a clip are capable of firing up to 600 rounds in less than 1 minute. And on top of that, when you look at who's buying them, this information becomes even more disconcerting. Because for the last 7 years, about 70% of all weapons that were sold in the world were purchased by developing countries. And where do you think 90% of those weapons come from? Let's just shout out some places. United States, about half. Russia, China, France, Britain, Germany, Canada's in the top 10 as well. But 90% of those weapons come from none other than the 5 permanent members of the United Nations Security Council, plus 1, which is Germany. The combined arms sales of the world's top 100 arms producing companies over the past 12 years, so since September 11th, have soared to more than $400 billion a year, which represents a 50% increase just over the past decade. Now you might say, but hang on a second. There was a war in Iraq, war in Afghanistan, Libya, and what about all those opposition fighters who've been trying to unseat despots in places like Syria? Don't the good guys also need weapons? Freedom fighters? And who are we to pass these kinds of moral judgments? Well, let's set aside arguments of right and wrong sides and good and bad guys for a second, because in my experience, war is rarely such a tidy narrative. Consider Egypt, which is still in the midst of ongoing political upheaval following a military coup, which took place earlier this year. And like Morsi, or Mohamed Morsi or not, and I can assure you that I certainly did not like Mohamed Morsi, what happened was a coup, and we still need to talk about it using the right kind of language, because that's the only way we can actually openly debate and discuss things. But Egypt, in the current military regime, was the second largest recipient of American military aid for more than 3 decades. Or consider that in Libya, for example, that the European Union, this is quite astonishing, between 2004 and 2010, the European Union approved more than $1 billion worth of arms export licensing agreements to that fallen dictator, Muammar Gaddafi, after the sanctions were lifted against him in 2004, but still at a time when the world knew that the cheese had already slid from that cracker. Right? And then consider that some of those arms have since been actively flowing from Libya into the Islamic Maghreb, into the hands of Al-Qaeda and Aqim, which is Al-Qaeda and the Islamic Maghreb, Mali, and into Somalia and the hands of Al-Shabaab. And we all know what happened in Kenya a few weeks ago as a result of Al-Shabaab's activities and arms possessions. Small arms do not ever recognize borders, which is why their first stop will never ever be their last. Even Mikhail Kalashnikov, and this is a direct quote, expressed regret that he did not invent a lawnmower instead. So yes, we can understand and respond to health challenges by adopting a narrow medical approach and by focusing on this immediate business of containing and reducing famine and disease. And we are certainly right not to ignore these urgent priorities. But when we take a step back and when we look at the ways in which policy questions are integral to our responses and in many ways determine their effectiveness, we begin to see why the bridge between these two disciplines, that narrative side of healthcare, why it becomes so vitally important. Improving health outcomes in war-torn countries like Somalia, for example, requires that we look at arms control, and I know this is a sensitive subject, and I know it's an especially sensitive subject in the state of Florida. But it requires that we look at arms control not as separate from global health and good public health policy, but as absolutely integral to it. And this means, for example, on an international level, upholding and supporting an international arms trade treaty called the Arms Trade Treaty, the ATT, which is bringing about restrictions around the sale and the transfer and the stockpiling of small and light weapons in the world. And the good news here is that a few weeks ago, President Obama, actually signed the Arms Trade Treaty, the International Arms Trade Treaty, despite active lobbying from the gun lobby here in America. And I am ashamed to say that Canada, which was one of the original architects of the Arms Trade Treaty 10 years ago, has still not signed it due to active lobbying on the part of our own gun lobby at home, which is really shameful and unfortunate. But we shouldn't stop there. And if you're interested in that particular issue, the website is controlarms.org, and these sites are all listed in the back of my book. We shouldn't stop there because in Somalia, like many other unstable places in the world where life expectancy is around 42 years of age, half of the population is under the age of 18. And of course, once war breaks out, the small proportion of children who were in school either drop out or those schools cease to function and they fall farther and farther behind. And they have very little access to income, except of course if you go off and work for the only employer in town. And guess who that is? That's war. And so the way to prevent conflict in such environments, the way to reduce such threats, is to ensure that young people in those environments have access to the tools and the resources that they need. That means education, that means economic development, and that means support for their livelihoods and skills training so that they have opportunities, which in turn reduces the appeal and the draw of militia groups and creates opportunity for those young people to grow and to thrive. And I'm very proud to say that this is actually the work that War Child focuses on all around the world. But light weapons and military munitions are not the only example of this bridge that exists between global health and public policy. And I'm going to give you another one. And this one, I guarantee, directly connects to each and every single one of you in this room. And I recognize that this is not an easy story to hear. But I think sometimes we stay away from conversations that are uncomfortable. And when we do that, we unfortunately reduce our ability to truly empathize. Because I think sometimes the appropriate response is to feel uncomfortable. And this story takes place in the Eastern Democratic Republic of Congo, which was formerly called Zaire. And it's a conflict that if you don't know much about, you should know something about it. Because it is a war that has killed more than 5 million people over the past 15 years. 5 million people. It's considered to be the worst war in terms of the numbers of civilians killed since World War II, and yet we hardly hear very much about it at all. When I was working in the Eastern Congo, this is a conflict that I am personally very lucky to have survived as well, because I ended up being evacuated from the Congo a few years ago when war broke out. But prior to this, I was sitting at an office that War Child had set up in this rehabilitation center for kids who had been affected by the conflict. It was a skills training program. And I had my computer in front of me, and my cell phone, my bottled water, and my private space. You know, all of these things that we kind of need and take for granted, right? And I've been interviewing kids all day, and so just as I was wrapping up, there's a knock on the door. And there's this young girl, and she asked if she could come in and sit down, and I thought she was coming in to give me some feedback on the program. So she came in and she sat down and she introduced herself. Her name was Nadine, and she was in her early teens. And she wasn't there to talk to me about her program. She actually had a completely different agenda in mind. She had a story that she wanted to tell, and she had a story that she wanted the world to hear. And she talked about how she had been in her village. She had been quite sick with malaria. When her mother handed her the money that she needed to go into town to buy her medication. So she put it in her pocket and she set off on this main road into town, very, very busy street, right along the Rwandan border, full of people and kids on their way to school. And she was surrounded by these 3 young boys. And she recognized them because they were from a neighboring village. Like a lot of young men in Congo, they'd been demobilized, so they'd handed in their weapons, and then they'd been sent back to communities that either didn't want them or had very little to offer them, and these were young men who were quite traumatized themselves. And these young boys surrounded her, and they pinned her down, and then they took turns raping her. And when she got up to run, one of them pulled out a hunting knife and then proceeded to slice off the soles of her feet. And then they raped her again. And as she told me this story, she slipped her feet out of both of her shoes, and she showed me these thick scars that she had that ran from her heels to her toes on both sides. And I can tell you, medically speaking, that I was astonished that she could actually walk. I mean, she must have been in pain with every step that she took. and then they raped her again. And she ended up being picked up by some young kids who were on their way to school, and they helped her to wash her clothes, and then they carried her home. And Nadine didn't ever tell her mother what had happened to her, because like other young girls in her village, those who are raped and those who are exposed to HIV have absolutely no hope of ever getting married, and it can sanction them to a lifetime of poverty and isolation. Do you know that 1 month after I had this conversation with Nadine in that office, on the same road into town, she was raped again? And the Congo is literally overrun with mothers and grandmothers and little girls and infants who have been brutally sexually assaulted as a result of the war in that country. And all of this has been taking place despite elections having occurred on 2 separate occasions since 2004, and despite the presence of more than 17,000 United Nations peacekeepers. So how do we tackle this global health challenge? Well, certainly there is a critical need for ongoing and expanded treatment programs for rape victims, as well as protection initiatives for women and children. And this is something that we as an organization have been actively involved in the Eastern Congo. But we can't stop there, because it isn't enough to treat women and then to send them back out. For those of you who work with high-risk women, you'll understand this too. And send them back out just to suffer the same fate all over again. But to understand the depth of this challenge, we also have to look at the international policy failures that have abetted this national rot. So what are some of those failures? Well, some people would say, you know what? The blame for this situation lies squarely at the feet of the Congolese government. They squandered, they cheated their way to elections, they've been blighted by corruption, and they need to do more to protect women and children from sexual violence within their borders. And that is true. And other people will say, and you know what, look how much we've got 17,000 peacekeepers there, we've spent billions of dollars on humanitarian aid to this part of the world. Most of it's been spectacularly mismanaged or wasted. Surely just adding more money to this problem isn't going to make it any better. And these are the kinds of reasons that people offer up for pretty much doing absolutely nothing at all about this situation, or feeling that it implicates any of us as human beings. And yet, we interact with this conflict, with its abuses and its excesses, every single day in the form of tin and tungsten and copper and coltan, all of which are actively mined from the Eastern Congo, and all of which can be found in our cell phones, and our computers, and our video game consoles. So let's just look at coltan, for example. Coltan looks like black coal. It is a conducting element, and the Congo is believed to contain between 60 to 80% of the world's coltan deposits. And you can't make a cell phone, you can't make an iPhone, you can't make an iPad without using coltan. And chances are you'll be using coltan that comes from the Eastern Congo. And it is readily smuggled across borders, in particular with Rwanda. The reason why Rwanda has been backing the M23 rebels has a lot to do with money and resources and profiteering that's taking place in that part of the world. But it is readily smuggled across borders and sold in exchange for cash and in exchange for weapons, and it generates hundreds of millions of dollars in illegal revenues every single year for Congolese guerrilla groups and military groups and mercenary groups and other war profiteers. And those who doubt the very direct relationship between the problem of rape in the Eastern Congo and the extractive industries that are taking place in that part of the world. There was a fascinating study that was published by some Congolese doctors a few years ago and published in the Public Library of Science. And for those of you who know your public health history, they applied one of the most basic demographic tools that we have to a particular question. And if you know a little bit about Typhoid Mary and how we discovered Typhoid Mary, it was the same methodology that was used here. So one of the questions that they asked women who were being treated at a referral center in the eastern Congo at Panzir Hospital in Bukavu, near the Rwandan border, one of the questions they asked thousands of women who were being treated there every month over the span of several years, they asked them where the rape had taken place. And remember, these are women who are coming from right across the eastern Congo. And then what they did was they plotted those cases on a map. And then guess what they did? They took another map of the mining areas, which are a magnet, as I said, for Congolese military groups, mercenary groups, and Rwandan-backed rebel groups, and other profiteers. And they put the two together. And guess what they found? They found that consistently, uniformly, right across the east, the closer you got to the mining areas, the higher the incidence of what is called rape with extreme violence, which by definition involves gang rape and the amputation of parts of a girl's anatomy, which is exactly what happened to Nadine. Do you know, I found out in the end why it was that she wanted to share her story. And it was because she was angry, understandably angry. And these were very hard words to hear, and these are words that I can tell you I reflect on every time I use a piece of technology. And she turned to me and she said, looking at my computer and my cell phone, we're speaking in French, and she said, "Tout ça c'est pour toi." All of this is for you. On meurt pour rien. You die for nothing. It's difficult to believe that change can take place in this environment. But one of the ways that change can take place is if we begin to understand and to prepare ourselves as health professionals that we really do need to do a better job of wrestling with this narrative side of health, with the ways in which the personal and the political and the historic and the economic all converge, so that we can better understand and address health's complexities moving forward. There is no doubt that change in war-torn countries is a multi-generational task. It means shifting the emphasis from the short-term Band-Aid solutions that can create aid dependency and undermine that local capacity, and instead focusing on those longer-term opportunities that put communities at the forefront of this process and is driven by the knowledge and the skills of insiders rather than the assumptions and the pretensions of outsiders. The enemy of effective aid often isn't innovation, it's inconsistency. There are no easy answers, there are no quick fixes. To effectively challenge these assumptions, all of us must endeavor to become more policy literate and to understand the many threads that bind us to violence and instability in other parts of the world, and to vigorously advocate for renewed and strengthened public policies that support smarter development, smarter humanitarian aid, and greater transparency, especially on the part of our multinational corporations. None of this will be easy. So what can you do? Well, I've got 4 very quick suggestions. I'm wrapping up in about 6 minutes here to leave you with this evening. They're kind of take-home messages by way of wrapping up. And as promised, they include some of the recommendations to the students on how you get started. The first that I have found, my first recommendation for you, and this is something I've found to be extremely important over the years, is that if you really want to make a difference, it begins by just staying informed and becoming more aware and literate yourself when it comes to international health and development. One of the ways that we break down our assumptions and our stereotypes about people living with war and poverty is to take the time to read. How many of the students here, how many of you read one piece of international news each and every single day. And I'm going to throw a caveat in here. By international news, I don't just mean every time Lindsay Lohan gets arrested and suddenly it's like that's international news. As relevant as that is to our collective futures. I mean, how often do you sit down, how many of you every day sit down and say, I'm going to read one piece of foreign policy news or human rights news or something about another part of the world and try to understand it? How many of you do that? Okay, so a few of you, but this is so critically important. It's often that piece of education that's missing. Sometimes we find these problems to be so big and so overwhelming, you don't even know where to begin. You don't know who the players are, and it all seems very complicated, and so it's really easy to just say, I don't know enough about it. But that's not actually good enough. In many instances, we are implicated in the suffering of other people, and it's by making those daily incremental investments that we will understand and have a better idea of where and how we might have an impact. And if you want some really good resources, my favorite, obviously Foreign Policy is fantastic. Relief Web, if you're not on Relief Web, it's great. It's reliefweb.int. The Economist is quite good. Don's Digest, which you can join, I think it's about $30 a year, and every week he goes through and he actually produces the sort of headlines on the most important development issues taking place in the world, and it's extremely good. If you're really interested in the coltan issue and extractive conflict resources, a great website is the initiative out of Washington. It's Pendergast's initiative called the Enough Project. That's the enoughproject.org, and you'll find some really good resources there. And of course, if you need additional help, some of these are addressed in more detail in my book, Damnations. My publisher will be very happy I just mentioned that. And I'm also on Twitter. I'm at Samantha Nutt, and I routinely post articles that I think are worthy of your attention and time, especially if I know how busy you all are. So number one is a commitment to knowledge and information and ongoing education. Number two, if you are interested specifically in international work, and maybe in doing what it is that I ended up doing, although remember your parents won't be happy with you, make sure you take the time to build your networks. I can't even tell you how often, this is the bane of my existence, I get emails from people that I've never known, I've never met them, maybe I've met them once, they're not donors to War Child's programming, they haven't been involved in any of our efforts. They haven't even attended any of our events. But they'll send me a note, and it will say, Dear Dr. Nutt, or Dear Sam, I have 2 weeks off this summer, and I was thinking I could work on your project in Afghanistan. This is not a winning strategy. If you remember nothing else from my presentation this evening, remember this. In general, people at aid agencies find these kinds of emails off-putting because for us, they are a great big flag that you actually do not know what the heck it is that you are doing. Because people who really understand development, who really understand the importance of local context, of sustainable programming, of investing in local community groups and local community organizations, wouldn't offer their unskilled labor to an organization for us to, at our expense, send you into one of the world's most dangerous places, let alone all the insurance and everything else that goes along with that. So instead, have a relationship with an organization. Show them that you are invested in them and in their work for the long haul, that you are committed to what it is that they are doing. One of the ways that you can do that, for example, is you can volunteer in their offices here at home. We have an office in New York that just opened. We also have an office in Toronto. We take paid summer students. We have volunteers that come through those offices as well. And we love people who are enthusiastic and who show up and who'll say, I'm going to do anything. I'll show up and lick envelopes and staple paper. I love that. And that to us, the fact that you want to be there and you want to learn, to us demonstrates that you're getting it right. And another way that you can do that is obviously if you want, even for me when I was at university, I was involved in a number of different NGO chapters, non-governmental organization chapters at my university. We have War Child chapters at universities and colleges right across Canada and the US in different locations. It is something you could certainly start here at UCF. And these are the kinds of things that are helpful. People recruit from those positions. We probably have about 60% of our current employees started in some fashion as volunteers with the organization. So getting on a plane should be the last in a series of steps and never the first. And if you just want to see the world, by all means, go and see the world. Buy yourself a ticket, get on a plane, go to Tanzania, do whatever you want to do. Spend your money in local markets, because that will do some good as well. So number 1 was about knowledge and information. Number 2 is about building your networks. Number 3, this is really quick, your donations really do matter, but know how to give. Too often we see a crisis in the news and we write a check and we walk away and then we say, why isn't it better in Haiti? As I've already said, these are generational challenges. The single most important demographic determinant of whether a child in the developing world will live to see his or her 5th birthday is that child's mother's access to income. It takes time. You are much better off giving a smaller amount of money as a donor on a monthly basis or a regular basis to an organization and having that relationship than writing a check and walking away and contributing to that cycle of aid dependency. So number 1 was knowledge and information. Number 2 was about your networks for the students. Number 3 was about your donations. And then lastly, and this is one I think that I have learned the hard way. It's a bit more of a philosophical proposition. Because to really make a difference in the lives of those who are living with war and violence and poverty around the world, or even here at home, it begins when we start to understand that despite all the illusions that we may have to the contrary, and despite all of the flawed narratives that we tell ourselves, aid and even charity really, it's not about what we do for others. It's not about the schools we think we built. It's not about the hospitals we think that we funded. It's not about the lives that we run around claiming that we have saved. It is instead about the space that is created for those who are living with war and poverty to simply do. When I first got on a plane to go to Somalia, I didn't fully understand that. But that was before I knew what it means to live with war. And I can tell you that I do know what it means to live with war now, because I have lived war's ruthlessness, and I am no longer seduced by its tales of heroism and altruism. For me, this work is deeply personal. It will forever remain unfinished. And because of that work, I do know now what it means, for better or for worse, to live with war and to listen in the darkest of nights to that crackle of automatic gunfire and to wonder how many more minutes I have left until it will be right on top of me. And it is a horrible, inescapable kind of fear. And yet it's the kind of fear that millions of people around the world have gone to sleep with this evening, and that we often forget about. Over the years of doing this work, war has killed far too many people close to me, particularly in Iraq. And on a couple of occasions, war has almost killed me. But I get up and I do what I do every single day because I believe that with the right amount of leadership and initiative, we can actually foster globally compassionate societies that actually make the right kinds of investments in the lives of those who are facing inordinate obstacles, and that will better sustain and strengthen our local and global communities. And I began by saying, here we go back to 50 cents, that the biggest lesson of my life was probably the cheapest part of my education, 50 cents. But to me, it's been absolutely invaluable. And so for anyone here, and this is for the students this evening, who feels that perhaps this evening this may have changed your perspective and how you feel about these issues, I have signed a copy of my speech, and I'm going to dedicate it to you, along with 2 Canadian quarters. You can't use them in the tolls. And you should feel free to come and collect it at the end of my presentation. Thank you.